What's up, everybody? Welcome back to Medicine with AUNO. We are going through 3 questions again today, and at the end, we'll do a quick jam session, so stay tuned for that, y'all. So let's dive right in. 35-year-old male taken to the ER after a motor vehicle accident. He had a physical examination which showed the scapula retracted laterally, which was on the affected side of his collision, I guess. An X-ray of the neck showed an injury to the dorsal surface of the neck and a fracture of the medial border of the right scapula. Which of the following nerves is most likely injured on that side? Axillary, long thoracic, dorsal scapular, greater occipital, suprascapular nerve. So they found the scapula was retracted laterally, so this is what they saw. Some lateral scapular winging. Remember in video 1 we talked about medial scapular winging. Here's our scapula. They took an X-ray and it showed a fracture of the medial border of the right scapula. Now this X-ray doesn't have a fracture, thankfully, because it's mine, so I'm glad I didn't have a scapular fracture. But here's the scapula on X-ray, and I believe that this is the here's inferior angle, medial border, and then superior angle of the scapula up here. I didn't have it filled out here, but I think it goes all the way up to here. I'm not sure, though. Y'all let me know. I'm pretty sure this continues up here. But here's our scapula on X-ray. And here's our medial border of that scapula. So, and on this side it's here. But this is the right side, right scapula. So, what nerve was injured, right? Due to this motor vehicle accident. So we have 2 nerves that can cause lateral winging of the scapula. And it can be either the dorsal scapular nerve, which I just gave the answer here, or the spinal accessory nerve, which isn't an answer choice. But this is because the dorsal scapular nerve innervates the rhomboid major and minor, which retract the scapula, right? So they they retract it. So medially, I guess, medial retraction of the scapula. So if those aren't working, then the scapula will be retracted laterally. It won't be able to be pulled towards the midline. And of course, this also innervates the levator scapulae, which is involved in retraction of the scapula. And the spinal accessory nerve also can cause this physical exam finding if it's injured, because it innervates the trapezius, and the middle trapezius also helps to retract the medially retract the scapula. So those are 2 possible answer choices. So C is the answer. Let's go through the others. So axillary nerve, if that was damaged, what would we see? We see paralysis of teres minor muscle and the deltoid muscle, because that's what it innervates. So around the shoulder. And you'd have loss of sensation in the regimental badge area, which is what this is right here. You would lose sensation over that area, which we don't see here in this patient. The long thoracic nerve, as we talked about extensively in the first video, if that's damaged, the serratus anterior muscle will not be working, and you will have medial scapular winging. And this is the answer choice C, which we talked about, but this is a nice diagram showing the rhomboid major and minor, as well as the levator scapulae, which is what this dorsal scapular nerve innervates. We can see it running down the medial border. And that's something I also want to point out. These nerves here run down the medial border, especially this right here. So that makes sense that it would be injured if you fracture the medial border of the right scapula. These others don't do that. But yeah, if this was injured, you see winging as well, but medially. And then this is the medial border scapula, dorsal scapular nerve, so it's really close to that, so it can be injured in a fracture at that area. And yeah, if these muscles aren't working, you will have, these pull the scapula towards midline, medially retracted. So if they're damaged and the nerve's not working, so the muscles aren't working, then the scapula is going to be laterally retracted. D, greater occipital nerve. So this is basically innervating the skin along the posterior region of the scalp to vertex. It innervates the scalp at the top of the head, over the ear, and over the parotid glands. So here's our greater occipital nerve. And then here's a lesser occipital nerve, and then there's also a third occipital nerve, I think, that comes up through here. Maybe I might have that. I don't know. I think so. And yeah, there's sensory distribution. So if you this gets damaged, you can develop, I believe, sensory loss over here, or maybe that's where you get this painful condition. So if the greater occipital nerves compress, it can cause something that's real painful, called occipital neuralgia. And it also can provide innervation to semispinalis capitis muscle. And the last option was the suprascapular nerve. So if this is injured, you'll have some vague shoulder pains and some weakness in the shoulder, abduction and external rotation, and later muscle atrophy. So here's our spinal accessory nerve. So we see that does run at the medial border of the scapula. That wasn't an answer choice, but that could have been correct. And here's our suprascapular nerve, which is more towards the lateral and middle of this. And this is going to innervate these two muscles here. Our infraspinatus and supraspinatus, which are pretty much on the posterior side of the scapula. Posterior, superior, and right here in the back. So that's what gets affected. So yeah, this is our answer, y'all. Next question. We have a 64-year-old brought to the emergency department because of a 4-day history of a painful rash and skin eruptions that are localized entirely on one side of his body. And this closely following the dermatome level of spinal nerve C7. The patient was diagnosed with a herpes zoster viral infection known as shingles. We all know what that is. And in which of the following structures has the virus most likely proliferated to cause the patient's current condition? So where has this virus resided at? Is it the sympathetic trunk, dorsal root ganglion, lateral horn, posterior cutaneous branch of dorsal ramus, or the ventral horn? So, herpes zoster, shingles, viral disease due to varicella zoster virus. Chicken pox is what comes first, childhood. A lot of people, y'all probably have had it. I did not actually get chicken pox, though. Adult chicken pox is worse, so hopefully I never get that. But this can be from initial infection with the varicella, VZV, whatever. The virus. And this virus can remain latent in nerve cells after the initial infection and may reactivate many years later due to stress or trauma. Here's our rashes, right? Chickenpox versus shingles. So it's pretty clear, like the chickenpox has these raised pink-red bumps that cover the entire body, even says internally, while shingles follows basically just one side of the body, typically torso or sometimes lower extremities, but not as common. But and these are blisters, but localized, right? This is more widespread in chickenpox. They both can crust and scab and take several days to heal here. Take about 1 to 2 weeks here. This is where it causes that rash. It's usually a wide single strip on the left or right side of the body or face, occasionally the extremities. It can cause burning pain, tingling pain, itching. It can be pretty bad. Rarely can go to like other places in the body and cause more serious complications. But yeah, this is not C7, obviously, that's a little lower. But here's a diagram of C7 dermatome. This upper back region. We can go out here. Here it is right here. So the rash probably right here. So, to the question though, where does this virus lie dormant in, and then proliferate? So herpes, this varicella zoster virus, initial infection with the virus usually during childhood causes chickenpox. The virus then moves to a dorsal root ganglion where it remains latent indefinitely. Dorsal root ganglion. And that is actually, later in adulthood, yeah, we already said this, it can reactivate. But yeah, obviously we know this is our answer, right? B. But we're not done here, right, y'all? Because we're going to learn a lot out of this. This is something I need to know. So varicella zoster virus lies dormant in the dorsal root ganglion within the spinal nerve. When the virus reactivates, it causes the painful skin lesions. Only involves the sensory nerve fibers. This is important. So this virus only involves sensory nerves, no motor involvement. So the dorsal root ganglion, which we'll see, is sensory, and that is where the virus will proliferate. So let's look at this. So here, let's look at this one up here first. So the virus is in this dorsal root ganglion. These are dorsal root ganglions. And then it goes out to either the ventral dorsal ramus, both of them, or something, and then it can cause these rashes here, shingles. Here's the dorsal root ganglion in blue, and then green is the, who knows, visceral sensory neurons. So yeah, these are sensory, right? Dorsal root, sensory. The ventral root is motor, so we know it's not it's not residing here. And okay, this is an important slide. So I was looking at this and it said it can go out this ventral ramus, and I'm like, that doesn't make sense because the ventral root is motor and this is sensory. So I'm not sure exactly what goes on here, but if the virus is in the dorsal root ganglion right here, then it can go out and see how these blue, whatever you call these, go through the ventral ramus and dorsal ramus. So they go through both. So it can go out the ventral ramus as well, or dorsal ramus. But it's not going to reside here because these are like solely motor neurons. Okay, so the other answer choices. Always want to rule out other answer choices, right? Sympathetic trunk. What is this? Sympathetic preganglionic fibers are visceral efferent fibers. Thus, they do not contain sensory information, which are afferent fibers. This is a major component of the autonomic nervous system, specifically sympathetic nervous system, and it runs on the lateral side of the vertebral bodies, all the way up from the skull to the coccyx. So, in this diagram, let's see, we see the dorsal root ganglion going out this way, gray matter, white matter, ventral root. So we have our ventral root here, and dorsal root here, spinal nerve, and then here's our sympathetic ganglion and sympathetic trunk, which was the answer choice. So the sympathetic trunk just runs from top down, lateral to the vertebral body, all the way down. And here we see superior cervical sympathetic ganglion and the trunk. And here's a, so I don't know a lot about this yet. Hopefully we will learn all this. But we can see that this is not, has nothing to do with shingles. The lateral horn. Okay, so the lateral horn is the small lateral projection. And it's located, it's in the gray matter, which is all right here, and it is located between the dorsal horn and the ventral horn. It contains the neuronal cell bodies of sympathetic nervous system. So again, lateral horn, sympathetic nervous system. Disruption of this can cause some eye symptoms, right? Ptosis, anhidrosis, I think that might be sweating, I don't know, meiosis. Again, y'all, I'm learning just like you, so we're in this together. I don't know any more than anyone else here, which is why I'm making these videos for all of us, especially myself. But we know lateral horn is not sensory. It's not motor. It's sympathetic, so it has nothing to do with this. Here's our dorsal root ganglion. That's where our answer is. That's where the virus will be. And again, that's somatic sensory nuclei, and this is the ventral root and horn is going to be our motor. Posterior cutaneous branch of dorsal ramus, the C7. Now this is interesting because the virus is not in the dorsal ramus when in the latent stage, but the cutaneous sensory branches will transmit the virus to the posterior skin of the back, and the dorsal rami send nerves to a small skin and muscle section of the back. So we'll see, where's our ventral ramus here, dorsal ramus here, spinal nerve, dorsal root ganglion. So here's where it's residing. So yeah, when it propagates, proliferates, and spreads out, it can definitely send through this dorsal ramus. The virus can go back that way to the skin and transmit the virus to that posterior skin of the back, as well as go out the ventral rami or ramus. So that's not the answer though, because the virus is not residing there though. And lastly, the ventral horn. So this is going to be this has our cell bodies of the motor neurons. So again, the dorsal horn is sensory, and ventral is for efferent fibers going out to control skeletal muscles. And shingles does not affect the muscles. So again, dorsal root ganglion, afferent fibers, sensory, and then the ventral root or anterior root is the efferent fibers going out to the muscles. So and that comes from gray matter here, the dorsal and ventral horns. So that question's good. So now question 3, we have a 45-year-old woman. She comes to the physician because she's experienced moderate pain for 2 years in her left lower back. Pain radiates down her left lower limb and has become a nuisance more recently. She says after lifting some soft drinks, the pain suddenly became intense. MRI was done. This is a good case here, y'all. So stay for this. MRI of the lumbar spine shows an intervertebral disc herniation between vertebral levels L4 and L5. Which of the following nerves is most likely affected by this disc herniation? So yeah, y'all want to watch this part. This is good. Hopefully y'all stayed this long. So the disc herniation, we see this intervertebral disc herniation pinches a nerve, but what nerve, right? What nerve is it going to pinch? And here is a herniated disc versus a normal disc, and compresses that nerve root. So herniated disc happens when a portion of the nucleus pushes through a crack in the annulus. So the annulus is tough and fibrous tissue. Nucleus pulposus, I think it's called. It's more like pulp and gelatinous maybe, but don't take my word on that. But symptoms can occur if this herniation compresses the nerve, pinches that nerve, so it just herniates through there. And we see that same thing here in the sagittal image, axial image, sagittal image, right? And here's a great illustration as well. Annulus fibrosus is here, and then this nucleus just herniates right through it, and then it infringes on the nerve. So let's talk about what nerve we're going to be actually affecting with an L4, L5 disc herniation. So here's an example here. This nerve's getting crushed. The MRI was done. This is the L4, L5 disc intervertebral disc herniation. 2 separate MRIs actually. So we can see right here the herniated disc. And this is what are these, you all? These are I don't even want to say because I'm not sure. I think they're cartilaginous. I think they're made of cartilage. I might be wrong. Obviously they're made of this stuff, but I should Google that though. But here it is right here. You can see this just pushing back into the nerve roots, cauda. The spinal cord, of course, ends at I think T12 or L1. And then, but yeah, it's compressing that nerve root. So this is probably the best image here. This is showing L4 nerve root and L5 nerve root. We can see L4 is between L4 and L5, the intervertebral disc. But actually, L5 is going to be the nerve root affected because watch, boom. So we see what happens here. L4 is fine. It runs right below the intervertebral foramen, I believe. And it's safe. It's protected. It's not going to get hit. But it's going to hit this part right here in yellow, which is going to send off this L5 nerve root. So the L5 nerve root is what's going to be affected in this patient here with the L4, L5 disc herniation. So that is the end of this video, y'all. We're going to do a quick piano sesh, and then we're going to call it a day. But I hope you all learned something. I sure did. Again, always look it up yourself. Talk to your professors because I know as much as y'all. Y'all might know way more than I do. So I'm just trying to give a little bit. Tried to do look some stuff up and did my best I could. So Anyways, y'all, let's do a quick piano sesh. Who knows how long this will be? Y'all can check out right now if you want, but we're just gonna jam out a little bit. So here we go.